organ transplantation as a medical procedure in which an organ is removed from the one body, living or deceased donor, and placed in a body of recipient to replace a non-functioning or missing organ. Since 1954, after the first successful human kidney transplant was performed, the solid organ transplantation has increased worldwide. This increase was due to the improvement in immunosuppressive agents. This improvement in immunosuppressive agents reduced the rejection rate with increase in side effect, including infectious complications and malignancy. As a general principle, the infection diagnosis with immunocompromised host is more difficult when comparing to the immunocompetent host, in which the patient may, the sign of inflammation may be reduced due to using immunosuppressants, including steroids. At the presentation, the dual infection or process are common in immunocompromised host. The infection is usually advanced during the presentation. Immunosuppressants and antimicrobial agents may exhibit a toxic effect, leading to reduce the sign or diminish the sign of infection in the immunocompromised host. Now we will move to our main topic, which is coronavirus disease 2019. It's an infectious disease caused by severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2. The disease first identified in December 2019 in Wuhan in China. This infection was declared as a pandemic from World Health Organization on March 18, 2020. Our knowledge is limited, actually in all population, including solid organ transplant patients, but based on similar viruses that infected transplant population, the immunocompromised patients remain infectious for longer than other COVID-19 patients. COVID-19 epidemiology, globally, there is more than 3 million confirmed cases nowadays have been reported. In Saudi Arabia, the cumulative incidence reached around 26,000 cases today as per Ministry of Health website. The pathogenesis of this disease started by the SARS coronavirus 2 bind to the lung through the angiotensin converting enzyme receptor 2, leading to enter to the host cell, leading to infection of the epithelial cells, leading to activation of immune cell, releasing of cytokine and chemokine. That will lead to severe disease or resolution. The course of COVID-19 infection has 3 stages. Stage 1, which is asymptomatic during viral response, which is a viral response phase, followed by stage 2, non-severe symptomatic, and stage 3, severe respiratory inflammatory involving cytokine syndrome. Sorry, can you hear me now?
Yes, doctor. Continue, please.
Regarding the transmission, the virus is transmitted via respiratory droplets, either by direct contact or indirect contact. Direct contact from person to person, or indirect through touching a surfaces contaminated with the virus. The median incubation period is estimated to be 5 days, ranged from 2 to 14 days. The gold standard for the diagnosis were PCR. Also, the sensitivity of PCR testing is different based on the sample source, ranging from 93% from bronchoalveolar lavage to 32% from oropharyngeal swab. The clinical suspicion and criteria for testing in a patient with a new onset fever and or respiratory tract symptoms, for example, cough and dyspnea, or patient with severe lower respiratory tract illness without any clear cause, or other consistent symptoms, including diarrhea or smell or taste loss, linked with an epidemiological link, and patients living or traveled within 14 days in an area with a high reported cases of COVID-19, or the patient has a close contact of suspected or confirmed cases of COVID-19 within the last 14 days, include healthcare system or setting. The clinical presentation for general population, usually with fever in 99% of the patients, followed by fatigue 70% of the patients, dry cough in 59% of the patients. Other reported symptoms include headache and sore throat. In organ transplant population, fever presented in 70% of the population in the reported cases. So those population may be presented with atypical symptoms, including GI symptoms like diarrhea. The spectrum of illness of severity is ranging from mild illness, pneumonia, severe pneumonia, acute respiratory distress syndrome, followed by sepsis and septic shock. The CDC was recognized the comorbidities as a risk factors for severe illness, including cardiovascular disease, diabetes mellitus, hypertension, chronic lung disease, cancer, and chronic kidney disease, obesity in patients with BMI more than 40, liver disease, and immunocompromised. Actually, the CDC include the immunocompromised condition based on the previous viral infection of immunocompromised host, but specific data for COVID-19 are still there. For donor recommendation in organ transplant patients, one of the risk of transmission of infection in transplant population is from donor through the donor-derived infection. Fortunately, there is no reported cases until now of donor-derived infection in COVID-19. But the virus is primarily isolated from respiratory tract, suggesting the lung is very high risk for transmission. However, there is a report of isolated viruses from the blood. Therefore, all organs may be at risk for acquisition of the virus. So, organ donors and recipients should be screened prior to transplant. The Saudi Center for Organ Transplantation raised a position statement regarding transplant population in this COVID-19 pandemic. They recommend for deceased donor to do a COVID-19 PCR from lower respiratory sample, bronchoalveolar lavage, or tracheal aspiration. If the patient has a positive test, we'll decline from donation. If the patient has a negative test, we will do a risk assessment. High-risk patients involving patients from geographic areas in the kingdom with a large number of cases, including Riyadh, Jeddah, Mecca, Al-Hafuf, and Al-Qatif, or the donor is from hospital with active COVID-19 cases. We will repeat the test for this high-risk patient. If it's positive, we will decline the donation. If it's negative, we will proceed with transplantation like in low-risk population. For living donor, we stratify the patients. As symptomatic or asymptomatic. If the patient has symptoms, we will decline the transplantation. For asymptomatic patients, the PCR should be done. The PCR will be done. If no contact with COVID-19 or other hotspot region of this COVID-19 pandemic, and the patient negative, we will proceed with the transplantation. If the patient contacted with a confirmed case COVID-19 and has positive, we'll decline the organ donation. If the patient have contacted with negative test, we will repeat the test after 4 days. If it's negative, we will proceed with transplantation. Regarding the transplant candidates, The transplant candidate, we will do the swab or screening for COVID-19 before transplant. If the swab came back negative and the patient has no contact with COVID-19 and not from a hotspot regions that mentioned earlier, the patient, we will proceed with the transplant. If the patient has contacted with confirmed COVID-19 case or from hotspot region, we'll repeat the test after 4 days. If it's negative, we will proceed with the transplant. If it's positive, it should be done as case by case after discussion with the multidisciplinary transplant. Now we'll move to the management of COVID-19 in general population, which is the second part of the presentation. Nowadays, the optimal approach for treatment of COVID-19 is uncertain. Also, there is no therapy proven to be effective. For most potential therapies, the evidence were from in vitro studies or observational case series and incidental use of this medication. I will go through the Saudi Ministry of Health protocol for patients confirmed with COVID-19. They stratify the patients according to the symptoms. If the patient has confirmed PCR for COVID-19 and asymptomatic patient, they give the supportive care is the main treatment or management following the instruction and recommendation published by Saudi CDC, and no antiviral required. For patients with mild to moderate symptoms, no oxygen requirement and no pneumonia, we will treat the symptoms and follow the instruction from Saudi CDC. Antiviral can be started with monotherapy of hydroxychloroquine, and if not available, we can start with chloroquine. For severe cases, those with symptoms with respiratory rate more than 30, blood oxygenation saturation less than 93, or lung infiltrates more than 50%. Supportive care with associated with treating the symptoms and follow instruction and recommendation by Saudi CDC. ICU admission is looked as a decision of ICU treating physician. Antibiotic and antifungal according to the local or institutional antiviral. The antivirals that can be used, hydroxychloroquine or chloroquine, and combination therapy of hydroxychloroquine, lopinavir or ritonavir can be used up to 10 days. For the critical cases or critical symptoms of acute respiratory distress syndrome, sepsis, altered consciousness, and multi-organ failure, or the patient with cytokine release syndrome, supportive care again with the treating the symptoms, following the instruction and recommendation published by the Saudi CDC. The antiviral therapy usually started with combination therapy, hydroxychloroquine with lopinavir and ritonavir, remdesivir if it's available. If the cytokine release syndrome confirmed, we consider tocilizumab as a single dose, 4 to 8 milligram per kg, and it may be repeated within 12 hours. This is a snapshot of Saudi Ministry of Health protocol. More data are available online for this protocol. Now, I will move to the management of COVID-19 transplant recipients, presenting an international experience of this disease within transplant population. I will start with a report from New York 2 Center, reported their 3 weeks experience during COVID-19 outbreak. They included adults more than 18 years with solid organ transplant recipient with COVID-19, retrospectively assessed between 13th of March till 3rd of April 2020. The patients were categorized as mild disease requiring outpatient care only, moderate disease admission to inpatient floor, and severe infection requiring mechanical ventilation or admission to ICU. Their objective is to compare between groups with mild, moderate, and severe COVID-19 infection. The initial therapy or an initial antiviral therapy for mild disease, supportive care mainly, moderate to severe disease, hydroxychloroquine or hydroxychloroquine in combination with azithromycin, tocilizumab for cytokine release syndrome, IVIG infusion, or polysteroids. For immunosuppressive therapy, they moderately decrease the overall amount of immunosuppression, emphasizing on decreasing or stopping antimetabolites, including mycophenolate mofetil or azacitidine. Their cohort, including 90 patients, their median age was 57 years, with 43 patients more than 60 years old. 59% of them were male, and 46 patients touched post-kidney transplant, followed by 17 with lung transplant, 13 liver transplant, 9 heart transplant, and 5 combined organ transplant, 3 having heart kidney transplant, 1 with liver kidney transplant, and 1 with kidney pancreas. The median time years of from transplant until diagnosis of COVID-19 were 6.64 years. 3 of the patients having COVID-19 in the first month and 13 within the first year. Regarding comorbidities, the hypertension was statistically significant, causing more severe disease in the patients, followed by active cancer. Presenting symptoms, 70% of the patients were presenting with fever, and atypical symptoms, including diarrhea, was in 30% of the patients. There is no statistically significant difference in baseline immunosuppressants, including CNI, mycophenolate, steroid, azacitidine, and pilavastatin. Their approach in changing immunosuppression was to decrease or hold antimetabolites in 88% of the patients, followed by 7% of the patient having decrease or hold in steroids, and 10 of the patient decrease or hold CNI, 5 of them in moderate disease status, and the other 5 in severe. The antiviral treatment in 91% of the patient with hydroxychloroquine, followed by 66% azithromycin, and 2 patients receiving remdesivir. The immunomodulatory therapy consists of polysteroid in 16 patients and tocilizumab in 14 patients. ICU admission were in 23 patients, 34% of the population, all of them with severe disease. Death occurred in 16 patients, all of them with severe disease. The discharge, 37 patients was discharged, 35 of them from moderate disease, and 2 of them from severe disease, 1 of the patient requiring readmission. In conclusion, for this initial report, in this initial cohort, transplant recipients with COVID-19 appear to have more severe outcomes. Also, they have testing limitation, led to undercounting the mild or asymptomatic cases. Because the transplant center tend to send the patient for quarantine 14 days if they have any symptoms, without screening them for COVID-19 or take the sample for COVID-19. That's why the reporting of mild or asymptomatic cases may be lower. As this outbreak is unfold, COVID-19 has the potential to severely impact solid organ transplant recipients. Now, I'll move to the report from Spain, single center case series. They reported 18 solid organ transplant patients with positive COVID-19 from March 23 till April 4th. 77% of the patients were male. Their median age was 71 years. The patients was 44% of them having kidney transplant, 33% with liver transplant, and 22% with heart transplant. The median time since transplantation was 9.3. The clinical presentation of the patients, 83% presented with fever. GI symptoms presented with 27.8. Respiratory failure in 27.8% of the patients. The therapeutic approach, including the antiviral, 9 from 18 patients, 50% of them receiving lopinavir and ritonavir. 8 patients from those 9 was combined with hydroxychloroquine. Monotherapy hydroxychloroquine was started in 5 patients. Interferon beta plus other agents was started in 3 patients. And IVIG in 2 patients, tocilizumab in 1 patient. Regarding the immunosuppressant management, started with CNI transitory discontinuation, or CNI dose reduction, mTOR conversion to tacrolimus, antimetabolite dose reduction, and prednisolone dose reduction. I will go through most of the cases in this reported population. The first case was for male 78 years of age, status post kidney transplant with maintenance immunosuppressant, including prednisone and tacrolimus, presented with fever and shortness of breath. The initial antiviral therapy was lopinavir and ritonavir at day 2. The management of immunosuppression, including reduction of tacrolimus dose, and the therapeutic outcome was or complication involving paroxysmal atrial fibrillation and acute respiratory distress syndrome at day 3. Unfortunately, the patient died at day 5. The third case was for male 80 years, presented status post kidney transplant. His maintenance immunosuppressant was prednisone, tacrolimus, and mycophenolic acid. Presented with shortness of breath, cough, and hypoxia. The initial antiviral was lopinavir, ritonavir, and hydroxychloroquine at day 7, started at day 7. The management of immunosuppression involving reduction of tacrolimus dose and discontinuation of mycophenolic acid. The patient developed delirium at day 10 and suspicion of bacterial superinfection at day 20. The patient outcome was persistent respiratory failure and multifocal consolidation at day 28. The case number 4 was for a female 71 years of age, that's post kidney transplant on maintenance immunosuppression, prednisone and tacrolimus mycophenolic acid, presented with fever, shortness of breath, and sore throat. The initial antiviral therapy was lopinavir, ritonavir, hydroxychloroquine day 7. The management of immunosuppression involving reduction of tacrolimus dose, discontinuation of mycophenolic acid, and prednisone. The patient has started on methylprednisolone and IVIG at day 10. Unfortunately, the patient died at day 60. For case number 6, male patient was 76 years old, status post kidney transplant, receiving a maintenance immunosuppression of prednisone and mycophenolate and rapamycin, presented with fever and rhinorrhea. The initial antiviral therapy was hydroxychloroquine on day 4. The management of immunosuppression involving discontinuation of mycophenolic acid, methylprednisolone started on day 6. The patient discharged home at day 13. Case number 7 was for male patient, 39 years of age, status post kidney transplant. Maintenance immunosuppression was prednisone and tacrolimus and everolimus. Patient presented with fever and myalgia. Initial antiviral therapy was hydroxychloroquine at day 1 as outpatient therapy. The management of immunosuppression involving discontinuation of tacrolimus and everolimus. The patient has hospital admission due to clinical worsening and bilateral consolidation at day 3. IVIG and methylprednisolone started at day 3. Tocilizumab started at day 8. The patient has severe acute respiratory distress syndrome, mild radiological improvement on day 60. Case number 9 was for 63 male patients with liver transplant. The maintenance immunosuppressant was everolimus. The patient presented with fever, shortness of breath, and diarrhea. The initial antiviral therapy was hydroxychloroquine at day 8, lopinavir and ritonavir at day 9. The management of immunosuppressants involving transitory conversion from everolimus to tacrolimus and mycophenolate, and there is no complication of therapeutic modification. The patient discharged to home on everolimus and mycophenolate day 15 and become asymptomatic at day 19. Patient case number 11 for female patient 79 years of age with liver transplant, maintenance immunosuppressant prednisone, azathioprine, and everolimus. The initial the patient presented with shortness of breath, cough, and diarrhea. The initial antiviral therapy was hydroxychloroquine and interferon beta at day 3. There is no changes in her immunosuppressant regimen, and there is no complication and therapeutic modification. The patient discharged home at day 14. Case number 14, it's 46-year-old female with liver transplant on maintenance immunotherapy, only tacrolimus, presented with diarrhea. Initial antiviral therapy, none, and she was discharged to home. No management of immunosuppression were required. There is no complication and therapeutic modification, and the patient requiring outpatient follow-up, asymptomatic until day 80. As conclusion of this single center case series from Spain, as of April 4, the case fatality rate was 27.8. After the follow-up, median follow-up of 18 days, from symptom onset, 30% of the patient developed progressive respiratory failure. 7.7%, which is one patient, showed stable clinical condition or improvement. 61% of them had been discharged to home. In conclusion, this frontline report suggests that SARS coronavirus 2 infection has severe course in solid organ transplant. Now we'll move to the Chinese experience with 10 renal transplant recipients with confirmed COVID-19 pneumonia, compared of 10 family members diagnosed with COVID-19. The intervention was immunosuppressant reduction and low-dose methylprednisolone therapy. The clinical outcome was severity of pneumonia, recovery rate, time of virus shedding, and length of illness. Eight of the patients were male. Their age ranging from 24 to 65 years. Their maintenance immunosuppressants were tacrolimus, mycophenolate, and prednisolone, or tacrolimus and mycophenolate, or cyclosporin and antimetabolite. The comorbidities, 6 of the patients has comorbidities like hypertension, chronic heart disease, or congestive or COPD. 9 of the patients were presenting with fever. 3 of them presented with diarrhea. The clinical condition ranging from mild in 2 patients, severe in 5 patients, and critical in 3 patients. 9 patients requiring antimetabolite discontinuation. 7 of them requiring 7 patients require CNI discontinuation, and 8 patients requiring CNI dose reduction. Corticosteroids, including IV methylprednisolone 20 to 40 milligram, was started in 8 patients. Also, IVIG started in 7 patients. 8 patients discharged home. They do a comparison of clinical feature and outcome of COVID-19 pneumonia in kidney transplant recipients and their family member. There is a statistically significant difference in onset of viral shedding, in which it's 28.4 days in kidney transplant recipients, comparing to 12.2 days in family member or general population. The onset of discharge was 35.3 days in kidney transplant recipients, compared to 18.8 days in family. In conclusion, immunosuppressive may have two opposing effects on COVID-19, making the early course of the disease more severe and prolonging the virus shedding time. But it may reduce the occurrence of fatal severe pneumonia by suppressing the hyperimmune response. After presenting this international experience, we'll go through practical points in managing transplant recipients with COVID-19. First of all, the treatment should be decided according to institutional guideline or protocol, and we should know that the immunosuppressive therapy should be individualized, case by case, balancing the risk of graft rejection against the risk of effective COVID-19 infection in individual patients. The proposed strategies, as published in previous case series for managing immunosuppressants, was either decreasing antimetabolite or discontinuing antimetabolite, especially in severely ill recipients. Some patients may require CNI and mTOR inhibitor dose reduction or temporary discontinuation. We should monitor closely the graft function of the patient. For corticosteroids, it may be reduced in severely ill recipients. For those patients who has a maintenance corticosteroid, should not be stopped abruptly. The high-dose steroids may be associated with prolonged viral shedding and possible poor outcome, as previously reported in other influenza viruses, Until now, there is no evidence supporting the IV corticosteroid use or systematic corticosteroid use unless there is an indication like exacerbation of chronic obstructive pulmonary. Main practical issue in managing transplant recipient is to manage the drug-drug interaction between immunosuppressants and the experimental COVID-19 therapies. The most drug associated with drug-drug interaction was leponapir and ritonavir, which is a well-known enzyme inhibitor, leading to increase the level of cyclosporin, sirolimus, antifrolimus, anticrolimus, may lead to toxic effect. In reported cases in patients with HIV receiving leponavir and ritonavir with tacrolimus, the patient have a low dose less than 1 milligram on weekly basis. For chloroquine and hydroxychloroquine, mainly associated with QT prolongation, it may initiate the effect of tacrolimus, which is mild effect in QT prolongation, but it warrant monitoring the patient for QT prolongation when using tacrolimus and hydroxychloroquine or chloroquine. There is a report case with hydroxychloroquine or chloroquine of post-transplant patients on cyclosporin receiving this hydroxychloroquine or chloroquine associated with increased level of cyclosporin. For tocilizumab, it adversely affects the CNI and mTOR inhibitor, leading to reduce their level. As you see from the previously presented slides, there is no proven treatment until now. So the key treatment issue is by profession. So we should instruct our transplant population and all the patients, all the community actually, to follow the recommendation of washing the hand and by soap and water or sanitizer, and keep social distance, cover their mouth and nose if there is any symptoms, and to seek medical attention if they have any symptoms suggesting or suspecting COVID-19, and to follow the direction from Ministry of Health and Saudi CDC.